Very excited to welcome you all to our virtual panel. The focus today is going to be on what's known as a D-SNP health plan, or health plan for dual eligibles. It's called a special needs plan. And we're really excited to talk to you today with a set of really deep experts who can help you understand what is a D-SNP, what are some of the important considerations for a D-SNP, whether you are a health plan thinking about adding a D-SNP line of business, a health plan that already has a D-SNP line of business, maybe you're looking at putting providers at risk, expanding your network, changing your product. Are you a health system that has a plan and you're thinking about adding the D-SNP line of business, or are you a health system thinking about launching a plan and having D-SNP be part of that launch or your trajectory? And there are other considerations as well. Certainly different types of providers across the industry who might be interested in understanding how to take risk in or grow their own D-SNP business. So we're very excited to talk to you about this today. There's a lot of movement nationally as we see more and more Medicare fee-for-service going to Medicare Advantage. We're also seeing a lot more states moving to put the Medicare Medis dual eligibles into managed care. So with that, Alice, it would be great if you could move to the next slide. I think you were there for a moment. So I'm going to ask each of my fellow panelists to briefly introduce themselves because I could never do them justice. And then I'll come back, briefly introduce myself, and we'll kick off. So we want to go Allison and then Anne and Carlene. Can you all please introduce yourselves to our guests?
My name is Allison Rizer. Thank you, Ellen, so much for the opportunity to be here today. I'm a principal with HCI Advisory, and I run our Medicaid, LTSS, and integrated programs work with Payer Solutions at HCI. I have touched managed care and SNP and Medicare and Medicaid for the better part of my career. I'm really looking forward to this conversation. I will pass it over to someone within circles.
Great, thank you.
Thanks, Allison. Hi, I'm Ann Tumlinson. I'm the founder and CEO of HCI Advisory. And if you're not familiar with us, we are based in Washington, D.C., but we have a lot of staff around the country. We're about 30 people, and we work with public and private leaders around in healthcare in solving some of the hardest problems in healthcare, which is where the D-SNP comes in. It's definitely one of the tough ones. And we offer very deep expertise, objective research, and we try to bring, a lot of ideas to the forefront and turn those into actionable strategies.
And my name is Carlene Zincke. I'm a registered nurse and principal and senior vice president of the medical management department at Cope Health Solution. Cope Health Solution is a consultant firm with 3 arms: analytics as well as workforce, helping partners to go to full risk and manage optimal care for our clients and our patients. I have worked in the healthcare space for over 35 years, 25 of which has been in managed care, managing D-SNP, at Medicare Advantage and Medicaid. Looking forward to our discussion today.
Thank you so much, Allison, Ann, and Carlene. So I'm Alan Miller. I have the pleasure and good fortune to get to work with Carlene and a team of about 110 or so people nationally. As Carlene mentioned, we're a tech-enabled solutions company, very much consulting, implementation, and what we call co-management for health plans, IPAs, and health systems. And we do have a lot of depth in the overall managed care space. So as Carlene said, a lot of the work we do is either help providers get into or succeed in risk, either directly or through an IPA, ACO, or CIN vehicle, or help health plans to build their networks, improve all of their medical management, and get their providers aligned in the right risk agreements. We build plans and IPAs and CINs, but we also do a lot of work for existing folks. And again, really pleased to be here. So we're going to keep going. Alice, if you could please move to the next slide. So a little bit of housekeeping. I'm not going to tell you where the bathrooms are. You already know that. But we do want you to absolutely provide questions. We're going to go ahead and go through a panel discussion where I'm going to ask some questions. Some were already submitted, by the way. and some questions for our panel. And then as we get toward the end, we'll probably take some live questions that you all are submitting, and Alice Chang on our end is monitoring those. You can either send them through the Q&A feature in Teams, and Alice provided a screenshot for you there. You can also email your questions directly to info@copehealthsolutions.com. After this meeting, you'll get a PDF copy of the deck. You'll also get a link to the recording. And we always create a written Q&A, so we take every question that was submitted before and during. We get answers to those from the panel, and we'll send that out to you. And we also send you a brief survey to see how we did, which we would really appreciate if you could please complete for us. Right, so what I'm going to do is I'm going to have Allison is going to provide a brief contextual overview of the D-SNP programs, and then we'll jump into Q&A. So Allison, handing it to you.
Here we go. Awesome. So what does dual eligibility even mean? So as all of you know, we have two major healthcare payers in this country. We have the Medicare program and the Medicaid program. And these programs were not designed to work together. They were designed really to serve different populations. So Medicare, of course, serving individuals who are older adults, age 65 and older, people with disabilities who might be younger than age 65, individuals with end-stage renal disease. And Medicaid may absolutely serve those populations, but Medicaid really designed to serve individuals with low income, extremely limited resources. And because these programs were designed really for different reasons and for different populations, there are different provider networks, coverage requirements, benefits. They just weren't designed to work together. But for 13 million people in our country, who we refer to as dual eligible individuals, or the dually eligible population, they have to navigate both programs because they are eligible for both programs. So if you could go to the next slide, Alice. I'm not going to rattle through all of these statistics, but I think they are important to have in mind. Sort of what is the profile of the dual eligible population? It really is a heterogeneous population. We're talking for the most part all ages, at least 21 and older. But by virtue of that Medicaid coverage and being extremely low income, and by virtue of that Medicare coverage having complex needs, this population, as you can kind of see with these statistics here, much higher rates of medical complexity, functional complexity, cognitive complexity, much higher rates of health-related social needs, behavioral health needs. And we've put them in the middle of two programs that, again, you're going to hear me say a lot, were not designed to work together. And as a consequence, this population tends to have much higher healthcare utilization and healthcare spending. They tend to have poor outcomes. And policymakers literally for decades have sought solutions to try to improve the experiences for dual eligible people, including through the D-SNP program that we are going to talk about today. So if you could go to the next slide, I'm going to provide a high-level overview of how D-SNPs fit into the healthcare landscape. D-SNPs are a type of Medicare Advantage product. So in Medicare, an individual can get their benefits administered through fee-for-service, or they can choose to enroll in Medicare Advantage. And Medicare Advantage typically has to enroll anyone who chooses to enroll in that product, except for special needs plans. Special needs plans are a subset of Medicare Advantage products that are limited to individuals who have certain circumstances. So in the case of D-SNPs, they're limited to people who are dually eligible for Medicare and Medicaid. A few really important components of D-SNP to be aware of that we will probably talk about in our panel discussion. The first is that D-SNPs are really the only Medicare Advantage product that have to have a contract with the state in which they are operating. This is referred to as the SMAC. It's a terrible acronym, the State Medicaid Agency Contract. But this SMAC is a very powerful tool for states to really lean into the D-SNP, again, a Medicare Advantage product, and really shape how the D-SNP serves Medicaid and Medicare dual eligibles in that state, whether that be limiting the specific types of dual eligibles who can enroll in the product, maybe it's influencing the benefits that can be offered or the clinical model. Another important attribute of D-SNPs is because they are a special needs plan, they have to have an approved model of care, capital MOC. Medicare Advantage plans all have clinical models. Special needs plans must have an approved model of care that they submit to CMS and NCQA that proves to CMS that they know this population. They have a specialized provider network, a specialized, individualized care planning process. And then a couple of other quick points about D-SNPs. all D-SNPs must, at a minimum, coordinate Medicaid benefits. So even though it's a Medicare Advantage product, it has to coordinate Medicaid benefits. It has to coordinate Medicaid appeals and grievances. That might be sharing data. And in some instances, that might include being at risk for Medicaid benefits as well. And then one last slide here, Alice, if you could go ahead. And so just a quick snapshot in terms of enrollment growth. This is all special needs plans enrollment growth over the past few years, but on the top of this graph, you can see D-SNP growth. We are hovering right around 5 million dual eligible individuals currently who are enrolled in D-SNPs. Pretty rapid growth over the past 5 years. So I think now is just a really perfect time to be having this conversation. And with that, I think that is my last slide. If you can go to the next one here, Alice. But I believe I'm going to be turning it back to Alan here. Yep, thank you. So with that, Alan, I will turn it back to you.
Thank you, Allison. That was really helpful. And the one thing I'll add, right, so you saw Allison's slide, you saw how D-SNP membership is going up. And there is a reason why ATI and CoPath Solutions have partnered together, aside from the fact that we really love working with Ann and Allison and their team. And we have team members who worked together before. So, but the other thing is that this population is growing. Why is it growing so fast, aside from the fact that people are getting older? Well, California, for instance, the biggest state in the country, is now requiring that if you're a Medicaid managed care plan, you actually have to also have a D-SNP, right? So what's happening nationally is we're seeing the states start to say, wait a minute, there's an opportunity for me to access some of these savings with the feds. And we're also seeing, of course, big picture, right? With the AHEAD program for global budgets, we're just seeing a lot of movement nationally with the feds and the states trying to come together and get everything organized into more consistent risk models across the board. And the duals are a big part of that because they're some of the biggest costs, right, in healthcare. So very excited to talk to you about this. I'm going to kick it off with a quick question. I'm going to start with Carlene, but then ask Ann and Allison to please jump in. One of the things I get asked about a lot nationally and that I hear about is, okay, if I'm a provider, if I'm a health system, for instance, or an IPA, what are some of the opportunities for me around how do I think about D-SNP as a provider? And I know you spent a lot of time on the plan side, Carlene, and the provider side. So maybe just some of your thoughts around, if I'm a health system, maybe starting there, what should I be thinking from starting my own plan or taking risk, or, what are some of the things I should be thinking about with relation to D-SNP?
I haven't worked on the health plan side. For providers, I think starting to take risk is the way to start this process. Building a robust care management program that will wrap that patient around, having an extensive network of providers that will be able to service the patients on all levels, not only custodially, but also in a skill setting, your specialists, your home care agencies. Having that wraparound of the patient makes a big difference in when you go to risk and you delegate, because you're going to be responsible for managing all of the care of that patient. And you need to develop a program that will be able to do all of those services in order to make reduce cost of care and increase quality of care for that client and keeping them home.
Great.
And
Ann or Allison, anything to add on that one?
I just want to jump in really quickly and say that, I think what we see is that providers can be nervous about entering into the Medicare Advantage program, much less entering into the special needs program. And I think what I would say is that, there's a lot of risk in not at least considering it very carefully. Most of the, particularly, and I think for those providers that are expressing interest, or that we are seeing across the country beginning to explore this option, what they are realizing is that the population, the dually eligible population, unmanaged in fee-for-service is showing up in their emergency rooms. And so you're serving this population one way or the other. The question becomes, how far upstream in the sort of kind of revenue world do you want to be? Do you want to be kind of downstream from another payer, kind of being the price taker, being in these terrible negotiating situations with plans? Or do we begin to actually have access to those Medicare Advantage dollars through a D-SNP or other types of special needs plans in order to be able to flexibly design clinical programs and finance those clinical programs, okay, through those Medicare Advantage dollars? And that is not necessarily sort of counter, it doesn't run counter to being an ACO. These things can all kind of happen in the same strategy. So
That's great. No, that's great. Sorry, I'm just answering someone who's asking if it's their sound system or ours. So I think that's super helpful. And I'm just going to expand on that a bit because I know all of us are spending a lot of time out in the industry, right, with these health systems. I'm going to stick to health systems for a moment, right, because they're going through a lot of challenges, right? They're all losing money. They're trying to figure out, I'd like to get into risk, but all of a sudden I'm not doing well. How do I invest? How do I make sure I'm going to be successful? And some of the health systems are looking at launching their own plan, which is very expensive. Others are looking, to Carlene's point, to start by getting into risk. Let's just talk for a minute about the systems. We have a client, for instance, I won't say what state or what client, of course, but they were thinking about launching their own plan. One of the things that held them back from D-SNP is the requirement to take on Medicaid managed care as well and go statewide, for instance. And so can we talk for a minute, maybe Allison and others, what are some of the barriers and considerations I should be thinking about if I'm a health system and I'm saying, hey, I'd love to start my own plan for D-SNP? What are some of the pitfalls I might need to be aware of up front?
This is a really good question. So I'll start with this, and I'm sure Ann and Carlene will fill in a little bit. So there are, to your example, Alan, there are a number of states who do require D-SNPs to have a Medicaid managed care contract to even offer the D-SNP. I was counting in my head before our call, actually, and it's at least 10, 12, 13 states that require this today. And the rationale is that the state really wants to create as integrated as an experience as they possibly can for a dual eligible person. And by limiting D-SNP contracts to organizations that are also at risk for the long-term care, they can create that more sort of, single experience for the person. So it is a very real barrier to entry in those markets for organizations that are, smaller, or health systems, or, honestly, even regional plans, to kind of come in and take on the full Medicaid risk. And again, to your point, especially when it is statewide and you are a health system that is maybe geographically limited to a certain corner of the state or a few counties in the state. That said, like I will say that we continue to see states very interested in provider-led organizations on the Medicaid side. And in some instances, thinking more flexibly about how they procure Medicaid managed care and maybe procuring it regionally, for example, to allow for provider-led organizations to come in. So they're not necessarily insurmountable barriers to entry, but they are very real. But I do see paths forward for provider organizations in these markets, because again, states are increasingly, really interested in organizations that are committed to the local community. They are employers of the local community, and they are providers serving the local community. So I think that is an area that I would emphasize as a path forward. And then just one other quick point, and then I'll hand it off to Carlene and Ann, is that there are states where there isn't Medicaid managed care, and D-SNP looks very different in those states. It's not necessarily an environment where you're going to be at risk for Medicaid. The sort of barrier to entry, or barrier, if you will, there is that you do still have to ensure that you can facilitate transitions of care for this population, right? They're going to move from a Medicare service to a Medicaid service. So can you do that? To Carlene's, I think Carlene made a point about, like, it's expensive, it's complex to do that, but can you do that? And can you be a partner to your state? But I'll pause and see, Ann or Carlene, if there are things that you would add into that.
Yeah.
I think you've
Well, no,
covered
this
it.
is
Good job.
I agree. I agree. It was fantastic. And so as we continue down this pathway, right, and to your point, Allison, we talk about regional plans and health systems both. There are, of course, national plans that we all work with that have a different scale, a different capability, and a lot of different expertise in-house, right? Regional plans and health systems might not have that level of experience and expertise. And so I talked about it was expensive, right? So we all know it costs a lot of money to put risk-based capital up. It costs money to hire people like us and build the plan out. It costs money to build your network and put your TPA in. So let's talk a bit about some of the strengths, and maybe I again can ask you, Carlene, just to kick off a bit. What are some of the reasons why, I'm a mission-driven regional health plan. I'm a mission-driven health system. I want to help people, but help me help my board and my executive team, my doctors come along with me. What are the strengths? What are the reasons why I should spend all that money? Make sure I overcome any barriers that, consider being statewide, for instance, if that's required, take a Medicaid contract. So what is this going to do for the people I'm trying to serve? How's it going to improve their life? How's it going to improve my doctors' lives?
I think because the population is wrapped around with both Medicaid and Medicare, this is a population that has been neglected. I wouldn't say has been more complex from the very beginning. They're bringing in to the health plan social determinants of health needs, health inequity issues, as well as complex medical care. And I think for a health plan to come in, build the appropriate model of care for that population, and service them within that model of care, the turnaround on that life will be tremendous. You can see the quality of life turnaround for many of those patients. And while there's a dollar proportionate increase in managing a D-SNP member versus a straight Medicare Advantage member, the services you give to that population will turn your community around, and therefore decrease total cost of care, increase quality of care, and satisfy both the community as well as your providers. And Allison?
Yeah, I mean, I think that's it's all spot on, Carlene. I mean, I think the thing I would add to it is, and you may have touched on this, like you're already serving this population and moving up the risk continuum. So if you more flexibility in that dollar it can be a really good thing, because this means that now you're not only going to have enough dollar to provide that per click service, but if you can coordinate and manage it well, then you're going to have room in that dollar to provide more holistic services, to address some of those social drivers that we know are contributing to increased hospital utilization, increased emergency department utilization. So like that piece of it too, I think is really important from a provider perspective or a health system perspective, that you're serving them already. Maximize that dollar that you're getting in a more holistic way for the population.
Yeah,
I think that's great. Yeah. Oh, sorry,
yeah,
Allison, go ahead.
I was just gonna say, I think that what I've seen a number of health systems, piloting or operating really innovative programs, particularly academic medical centers that, they've launched dementia programs, they've launched family caregiving programs, and there's so many things, and they're funding those out of grant dollars, foundation dollars, and many of those can actually be integrated into the clinical model that ultimately they're using and be funded through a sustainable funding stream that is a lot more, and enable them to serve more people and scale some of those really innovative models that we don't typically tend to see in other organizations.
I totally agree, and I think it's you three are aligned so well, because Carlene talked about taking risk, which you can do without having your own health plan, but you have to have a health plan partner. We've been talking about launching health plans. So let me take a step back for a minute then to help folks on the phone who might not be as familiar with these special needs populations, because in healthcare, I remember when I was a kid, that's a liver. Everything's kind of classified in healthcare. We love our acronyms. D-SNP, right? As much as it's not, it's a separate, right, part of Medicare Advantage. It's not Medicaid managed care. It's this special pool. In itself, though, there's a pretty broad variety of folks who are D-SNP eligible. One question we got ahead of time, for instance, is, what about children? So I don't know, Anne, if you want to kick it off, or whoever would like to jump in and talk a bit about the types of populations in this program, despite the fact that it's fairly narrow, the diversity that we see there.
Yeah, no, thank you. That's a great question. And, people who are dually eligible are, so by definition, that means eligible for Medicare and Medicaid. Being eligible for Medicare, let's just take the older adult population for a minute, is a pretty straightforward thing. Almost all older adults are on Medicare. Being eligible for Medicaid, happens as a result of a wide variety of different circumstances in somebody's life. So you have people who have, behavioral health, who primarily experience behavioral health needs, housing insecurity, other kinds of severe financial insecurity as kind of the primary pathway through which they become eligible for Medicaid. Also, you have a population that has a lot of long-term service and support needs. And those individuals are, what that basically means is that they're experiencing pretty significant functional decline to the point where their needs are such that they could be, a nursing home would actually be an appropriate setting for them. So you'll actually have dual eligibles living in nursing homes. You have dual eligibles living in the community, but receiving home and community-based services in order to sustain them in their home, with help with activities of daily living and things like that. And then you have people who do not have long-term service supports needs, but, are under age 65 maybe, and experiencing other kinds of healthcare and financial insecurity and healthcare crises and chronic conditions and things like that. So I'm sure I've missed a lot of nuances here. So I'll let Allison and Carlene fill in. Long-term care.
I know, I
is
love
the
it
one.
because you hit you hit the really important strategic points, and I get way too weedy, way too fast. So I appreciate you setting it up that way. And I mean, you're spot on. And Alan, back to I think the question, like, what can you serve kids, for example? It's extremely rare that a child under the age of 18 will be dually eligible, because it is extremely rare that they will have Medicare eligibility unless they have end-stage renal disease, which happens. But just proportionally, end-stage renal disease makes up 1% of Medicare beneficiaries, and half of that percent is over the age of 65. So it's most 99.999% of dual eligible individuals are going to be 21 years and older. But it is an extremely heterogeneous population. Individuals with intellectual developmental disabilities, individuals with, late stage dementia, but also individuals who are what the industry calls community well. They're older adults and they're low income, but they don't necessarily yet have the sort of, cognitive or functional decline that requires long-term services and supports. So you do need to think about a very heterogeneous set of clinical models as well to kind of meet this population's needs. And it's one of the reasons we see a handful of states that actually have separate programs. They have a 65 and older dual eligible program, and then they have an under 65 dual eligible program. So that's the only additional nuance that I will add. And I thought you did a really good job at talking about the heterogeneity of the population.
Great. And I'm just going to be honest, you guys, my battery is running out right now. This never happened to any of you. I was running out of batteries and I thought I was going to fall off the team. So I'm here. So look, this is great, and by the way, I will say we've gotten some specific questions. So folks on the phone who ask more specific questions, we will get back to you individually. Things like organ specific questions about D-SNP. We're probably going to keep it a little bit higher level for this one, but maybe again, I'll kind of kick it off with Carlene again to think about. Carlene, if you could help us understand, going back to your first comment, like I can't go launch a health plan, right? I'm an IPA, I'm an FQHC, I'm a health system. I'm not going to launch a health plan today. The RBC is too high. Maybe there's not a procurement available in my state, right? Some of the barriers are simply impossible at this point. So can you talk about some of the considerations for taking risks? I think Allison and Ann have done a great job saying, hey, you can take risk, right? Can you talk a little bit about what that means to take risk, Carlene, and what that means across your other lines of business, like Medicare Advantage, an ACO return, MSSP, or Medicaid Managed Care? How does it help to do that with D-SNP, and how does it all kind of come together strategically for you?
Carlene, you are on mute.
Carlene, you're on mute. Sorry.
I'm having a wonderful conversation with myself. Taking risk. It, like Ann and Allison has said, it's a big thing. It is scary, but once you look across your line of business and you talk about Medicaid and we talk about straight Medicare, that Medicaid person that is coming into 65 and aging into Medicare, that's your sweet spot, because you haven't really managed that Medicare person, and so as they come in, you are now going to wrap them with services to make sure that they can manage, and taking risk along all of the other lines, as it's strategically along the other lines of business. you know your population, you know your Medicaid population, you know your managed Medicare population. You can bring those together to satisfy your D-SNP product, as long as you have a SMAC in the state that requires a SMAC. And it it sets you up for a greater relationship with your payers and your other providers and your partners, as well as it helps CMS work show your extension in services and your capabilities in managing this population. You're doing that model of care, and your risk is going to become easier to understand if you do your model of care, you manage that population well. And it's getting that CMS approval for your model of care that makes you're better able to manage that population. Allison, and
I think that the one thing I might add is that if you already have a Medicare Advantage plan and you might be thinking, why would I launch another Medicare Advantage plan? That seems like a headache I don't need. But actually, what it does is, because of the wonderful opportunity in the special needs plan to essentially limit enrollment to this population that has this set of characteristics, and the requirement actually that you have to develop what's called a model of care, capital M and capital C, is that you also get to craft a benefits package and kind of and clinical processes and quality improvement activities that are very much geared towards this population. So you're attracting this population into a product that is very much designed to serve them better than any, and dual eligibles are going to be served much better in a D-SNP than a Medicare Advantage plan. So, segmenting the populations that way can often be a really good way, not only to manage your own actuarial risk, but also to manage the care of the populations that you're trying to serve.
This is great, guys. Thank you so much. And we're getting some good questions in. So let me pivot a little bit differently then. So we've talked about regional plans, we talked about health systems. A lot of the FQHCs in particular, they're launching a program for dual eligibles, but it's not D-SNP. So I'm on the phone, I'm getting comfortable now with D-SNP. It's exciting. I know it could be kids, all these different types of folks. But oh my gosh, there's this other thing, and it's called PACE. Now I'm confused again, right? And I'm seeing CMS say do more PACE, and I'm seeing the states say do more PACE, and at the same time they're saying do more D-SNP. And so I don't know, Ian or Allison or Carlene or whoever would like to maybe kind of kick off and talk a bit about PACE versus D-SNP and how are they complementary with each other? Why are they both being pushed in parallel? What are the differences and similarities? Sorry, it's a big question, but just wanted to kind of kick that off.
I can start. I'm like, we all have so many things to say on this. I will start. So for those who might not be familiar with PACE, it's more of a brick and mortar model, an adult day center kind of environment. The population tends to be dual eligible. It's like 90-something% who are dually eligible who are in the PACE program, and it's 55 and older. So it overlaps with D-SNP, but it is a subset generally of who D-SNP programs will serve. The barriers to entry are arguably higher, I think, maybe for PACE, unless you have to stand up a Medicaid plan. The barriers for entry to PACE are probably as expensive as they are to stand up a Medicaid plan. I mean, we're talking the millions of dollars to stand them up. It's consequential. The care model in PACE, I think, can be really special, though, because the difference in PACE is that you get essentially a holistic set of dollars. You get your Medicare dollar and your Medicaid dollar. But it doesn't really matter if it's a Medicare dollar or a Medicaid dollar. It's just a dollar. So you can serve the person the way it makes sense to serve the person. So as we're talking about risk and having flexibility with a dollar, you truly have flexibility in PACE. But because of the brick and mortar aspect, it's, you know, it's not quite as scalable, or to date, it hasn't been quite as scalable. In D-SNP, you can't blend the dollar. You get the Medicare dollar and you've got to encounter back to CMS. You get the Medicaid dollar and you've got to encounter back to the state. So there are still financial misaligned incentives that exist in D-SNP. I think ultimately it comes down to, and I'm sure Anne has like so many thoughts that she wants to say right now, and Carlene probably does too. PACE, I think, is much more of like a provider clinical model, whereas I think of D-SNP has that, but it's more of an insurance as well. So I think there's definitely an opportunity to think about both, and we see a lot of organizations thinking about both and even partnering with one another. But there are some, I think, really important differences. And Anne is kick me if there's anything that I'm saying that you disagree with, or Carlene. I'm like, I feel like we could do a whole session on just this topic.
Yeah, PACE has been
That's
growing
another
really
session.
quickly. Oh, go ahead, Carlene. Sorry.
I was saying to Allison, PACE is a whole other webinar.
It's been growing, like we're seeing PACE has like had this lovely little resurgence recently, I think partly because CMS opened the door for-profit PACE, and so we've seen some influx of private capital into the space, and the recognition that when you do get kind of unfettered access to a Medicare and a Medicaid premium dollar, and it's not unfettered because there's obviously there are a lot of requirements around the model, the care model, and the kind of physical environment, but there's a lot that you can do with that dollar, and it can be both really good for the beneficiaries and also profitable. So that's why we've seen a lot of capital come into that space, and we're starting to see PACE, seeing more and more states are looking at it. And of course, also there's a lot of policy. There are a lot of other kind of policy environmental factors that have sort of spurred PACE, and some of that has been sort of the dismantling of the ACA demonstration programs for dual eligible integration.
Yeah, and what I would add is what we see a lot with our clients nationally is that it's not either or, right? So you can have a PACE program and you can take risk for D-SNP, Medicare Advantage, Medicaid, to what Carlene had kicked off and Ann had talked about. You can have a PACE program and a health plan for certain lines of business and take risk. So the one thing to keep in mind is it's all about managing that premium dollar to provide the best care to members, right? And create the best care model. And so it's just another great option. So it's been exciting to people. Okay,
Yeah.
so the other thing, sorry, Ann, go ahead.
Oh, I just want to say one more thing. I just think like what you just said made me think the key is to think through your broader strategy. Like it's just, none of these things may be right for an organization, but it's just important to have made that decision very deliberately. Are we going to do it? There's this whole world now of opportunities for provider organizations to have more control over their own destiny through the management of value-based care in the broadest possible sense. So being a Medicare Advantage plan, being a SNP, being a PACE, doing an ACO, different types of ACOs, being under a total cost of care contract with a Medicare Advantage plan. These are all options, and every market is different, every provider organization is different, every policy environment is different. And so the key is really just to take your teams through an exercise of understanding what the options are, where your organization is going, are these things aligned, what's aligned with your larger strategy and your goals and your mission, and then putting the things in place and making the investments to move along that continuum of risk, because that's where it's all going. And fee for service is only going to be increasingly, intensified in terms of its price pressures for units of service.
Yeah, I totally agree. And I mean, one of the things we spend a lot of time with health systems, IPAs, even in health plans on, right, when we're going through that initial strategy phase is, hey, who do you want to take care of? And that goes to our conversation, right? So when we say, who do you want to take care of? What kinds of coverage do the people you want to take care of fit into, right? What are their demographics? Where do they live? What geography do you want to cover? And what services do you want to provide? Not just, do I want to do cardiology or primary care, but do I want to provide the care management to my members? Do I want to be responsible for credentialing and provider identification? So I think you're right, and it's really important as we talk about this, and the reason we're sharing this is because there is a lot of interest. One of the filters to use for your organization is to understand, first of all, who do I want to serve? What services do I want to provide to them? And when you understand that in your geography, then you can kind of say, okay, well, how do these things fit, right? It's much easier to look at them. I'm going to make another pivot because I know we've got about 15 minutes left and there's another big topic. I'm sure there'll be others. But one of the other big topics that we see a lot right now with intersections, right, is these waivers, these Medicaid waivers. And I'm not going to pretend to be an expert on Medicaid waivers. There are so many Medicaid waivers, but there is a type of a Medicaid waiver called an 1115 Medicaid waiver, which is a transformation waiver, often focused on getting people into more value-based payments, lately also focused on integrating social determinants of care, and of course, equality and equity. And so what I wanted to ask folks to weigh in on now is let's talk a bit about California and New York, for instance, those have very large scale Medicaid waivers, right? California has CalAIM that's up and running, has another 3 years or so. New York is about to launch, we hope in January, a 3.5-year waiver, right, which will be very similar to California's CalAIM waiver. Other waivers were approved in the recent year or so. I think Massachusetts, maybe Oregon, if I recall. And so how does that intersect with this whole D-SNP conversation, if it does, with relation to, again, my strategic decision-making, understanding whether or not this is something, is it going to align with where the waivers are trying to go? What is CMS and the state's trying to do here? So big question. I'm sure you guys can break it down really well. I'll throw it to whoever wants to jump in first.
I'll start again with this one. We actually just finished writing a waiver for a state, as it turns out, on health-related social needs. So it's an interesting question, Alan, because in most instances, there's not actually an intentionality at like the CMS level to integrate the waivers with D-SNPs. Like they are happening mutually exclusively in many, many instances. And as you were saying that, I was trying to think through my head, like, can I think of 1115s that were like specifically about integrating with D-SNP? 1115 is going to be more about like the whole program environment. And so where I see it trickling down into the D-SNP space is, for example, like, or CalAIM is maybe a good example, where it says, okay, we're going to do these new in lieu of services as part of, you don't need a waiver to do that, but as part of this waiver, we're going to do in lieu of services, or we're going to require some sort of, increased focus on health related social needs. And as a D-SNP coming in and partnering with the Medicaid managed care plans who are administering that waiver, or partnering with the providers who are administering that waiver, like the state ostensibly could require through the SMAC you to really coordinate in that space, for you as a D-SNP, maybe through your model of care, to say, how are you going to invest in health-related social needs? How are you going to demonstrate that you align with our goals in our 1115 or in our broader program strategy? But like, I actually really like the question, because there really is like no intentional integration. We're talking about integration. There's no really intentional policy integration right now, again, kind of at that CMS level, because you've got one shop that is approving these, often very innovative 1115s, and another shop that is, pushing integration for D-SNP. So with this is another one like PACE, like, my gosh, we could spend a whole entire hour more day on this topic, but I will stop there at that very high level and see if there are other comments that Carlene or Ann would add.
Let me shape it a bit more, because I think that's perfect. You went exactly where I wanted to go. And part of the reason I wanted to bring this up is because Anne got me started on strategy, right? And this whole idea of creating your strategy and driving your strategy. And so a lot of our clients, both of us, right, are in these waiver states, and they're seeing all this happening, and it's happening to them, right? And so in California, for instance, you have the enhanced care management program as part of the CalAIM waiver, right? Carlene is our medical management person. She's talking to people across our health plan and provider plans right now, and they've got I've got my own complex care management, disease management care coordination program for my health plan. I've got the delegated IPAs that have their own care management right now. I got this ECM thing. Oh my gosh, how does it all fit? And I've got these services I can provide, housing and food. And so, and maybe I'll kick it to Carlene for a minute. And talking about Carlene, as we look at the waivers with the D-SNP programs and some of the other environmental factors, how does a provider, for instance, who wants to take risk or wants to launch a plan, how do they think about it strategically and operationally, their care model? And how do I pull these things in to power my care model versus having 100 different care models and care management programs? I see Carlene looking up. I know it's a tough question, but I figured I'd just throw it out there.
I think your care model should, um, I, I would present to any, provider, as you build your care model or you build out your model of care, as you bring in the basics, social determinants of health inequity questions, those things are standard across the board, not only for D-SNP, but it's for any of the waivers. How do you do feet on the street? How do you use community health workers to get the patients connected? That's still the basic tried and true model of care management. It's bringing all of those pieces together. And no matter what program you're working with, if you have that as the foundation, you should be able to manage within the waiver, without the waiver, and with just the standard D-SNP product. It's bringing all of those pieces together. You need to know your Medicaid product, and you need to know your Medicare product, what covers, what doesn't cover. But at the same time, if you're bringing those basic tools together, you should be able to manage either one of those programs. Anne or Allison?
I mean,
Well,
I'm
you know, I
hearing,
think,
sorry, go ahead, Allison.
well, I think this is like, and there are waivers that are completely carved out of managed care and D-SNP, but I think it raises kind of a bigger sort of philosophical, it almost, it substantiates the points that everyone was making earlier about the provider kind of having risk, because then you can be more in control of the clinical model that you are developing, you know? And so if you as a provider are going to be subject to the requirements in an 1115 or 19, whatever the waiver is that you're subject to, and you're going to be required to, you know, follow what the managed care plans in the state are telling you, whether that's on the Medicare or Medicaid side, it's not easy, but you can control that environment more if you are the risk bearing entity. So I think that's kind of the thread through all of this, you know, the past half hour or so that I would say here, Alan, kind of in the question that you're asking.
Yeah, that's what I was going to say is at the end of the day, I think what's important for folks on the phone to understand is, you know, D-SNP is just another way. And I think Allison and Ian, you said this, it's just another way to grab premium. You know, Carlene talked about taking risk, right? And so you grab premium so you can take care of people better. And so what Carlene was talking about is, it sounds like one single evidence-based care model. We know what the evidence base is. Don't let the D-SNP model of care, the ECM program in Carlene, whatever New York does, right? All of these different things moving around. Don't let them confuse you. At the end of the day, an evidence-based, risk-adjusted care model that is population-specific with the staffing ratios and everything, that's something you can have, to Carlene's point, singularly and consistently, versus, again, what we often see with clients when we walk in the door is, believe it or not, you have something 10 or 20, if it's a public hospital, maybe 50 different care management programs, because they just kept adding a new one every time there was a waiver or a grant or a program. And so, you know, it goes back to who do you want to take care of and how do you want to take care of them, right? And having a care model. So, I mean, thank you, Carlene and Allison. I think that makes sense. So we have about 8 minutes. We haven't gotten a new question just now from folks. So I would ask Carlene, Allison, and Anne, what I think the best thing to do is, let's do a bit of a round robin. You know, what would be the 2 or 3 other key takeaways you want everybody on the phone to hear? And maybe if it's okay, I can pick off with you, Anne, or if you want to defer to somebody else, but just kind of like 2, 3 key takeaways you want people to understand as we've gone through this.
Yeah, thank you. Well, first of all, Alan and Carlene, thank you so much for partnering with us, and hosting us and doing all of the work to make this happen. And I love having these conversations and the chance to kind of share our expertise with a new and different audience. So yeah, I would just say that I'm going to introduce a new idea rather than recap, but just the new idea a little bit is this population is growing. So the older adult population is getting older. We're migrating from like 60s to 75s the baby boomers are getting older and older. And that puts them more at risk for dual eligibility because of the increased risk for, illness related financial insecurity and functional decline. So, I really just think it's imperative that any organization that really thinks of itself as being kind of central to its community and serving its community, and that wants to thrive and continue to evolve in the future, is going to have to think about how it's going to serve not just older adults, but older adults who have significant levels of both healthcare needs and social needs, and many of whom will be dually eligible for Medicare and Medicaid, and that poses a very unique set of problems for them, and that there is fortunately actually a policy pathway to serving them in a model that actually gives you a lot of control over how you're going to do that. And so we're big. So I mean, maybe the big takeaway is, like, at ATI, we're really big fans of the D-SNP, particularly when it's really truly integrated with the Medicaid side.
I'm going to pause this for just a minute before I go to Allison and Carlene, because I see that Brian Smith has a question, and Alice Chang on our team, who does all this work in her wisdom, does not allow me to let people ask their question. Brian, would you mind putting your question in the message chat for me? And then what I can do is I can read it and address it. Meanwhile, I'll have either Allison or Carlene continue with the thread of the key issues.
I can add in real quick, Carlene,
Yeah,
and
go
then
ahead. Go ahead.
yeah, I was going to actually answer something kind of similar to where Anne was going, but like as the population is growing in this space, but you know, D-SNP is kind of the key path forward for this population. And there are definitely other programs. We didn't talk about the I-SNP model at all, but you know, Anne touched on nursing facility. That's an important model. We touched a little bit on PACE, but like the most prevalent path forward is D-SNP. And it is now, as of 2018, permanently authorized. It used to be a demonstration. And that's where, in that graph that I had, that you saw the enrollment increase all of a sudden. And part of that was suddenly the market was confident in investing in D-SNP because now it's permanent. And it is in 47 states, I think. Like, states are increasingly comfortable with it. Federal policymakers are, the Hill is, providers are, beneficiaries are, consumer advocates are. So like, this is the space to me that if you want to serve dual eligible individuals in a very targeted way, this is the program to be looking at, because it's the program that really truly is limited to dual eligible people across the spectrum of their needs. And I don't think it's going anywhere. Like, it really is the program that we are going to be looking forward at for the years to come.
Perfect. And Carlene, just before you jump in with your kind of key takeaways, Brian did do us the service of documenting his question. Brian's question is, how about supplemental benefits opportunities aimed at caregiver supports and rewards for meeting defined KPIs? Carlene, you're laughing. Do you want to take a stab at that one?
That I've been in the space where you're asking that question, because we confuse the supplemental benefits that's in Medicare Advantage and versus what's in a D-SNP product, and where that piece is. So don't confuse it, because the supplemental benefits that's in Medicare is actually similar, or if not completely covered under the Medicaid benefit for a lot of our D-SNP population. So it depends on which one of the D-SNP programs you're a part of, a totally integrated D-SNP program or an MLTC or LTSS, where some of that Medicaid benefit sits with the state. That caregiver support sits outside there, and you can do some more work, utilization around that population. And I see you had the same reaction I did, so I'll end on.
I'm going to let Allison answer this question, but I love the question because it's something that we're really excited and interested about and appreciate. We're going to dive deep down now for a minute into the supplemental benefit space, which is awesome.
Yeah. So, and I'm actually I'm gonna pull way up real fast and then deep dive, because I don't know if everyone is familiar with supplemental benefits who's listening right now, but Medicare Advantage plans have to cover your core Medicare benefits, right? All Medicare Advantage plans, including D-SNPs, have to cover your core Medicare benefits. And then there are a variety of ways that they can cover extras. So typically you see this in the shape of dental, vision, and hearing. Like, those are table stakes supplemental benefits that 99.9% of Medicare Advantage plans offer. And then there are these newer, over the last few years, non-medical benefits, caregiver supports being one of them, in-home support services, non-medical transportation, food, social benefits, this whole host of non-medical supplemental benefits. I will say the dollars are small. Like these aren't additional dollars that Medicare Advantage plans have to offer. They've got to figure out, again, going back to that risk, that dollar, they've got a little bit extra in the dollar if they're efficient to provide these supplemental benefits. Carlene is right in that in some instances, a dual eligible person through their Medicaid might be receiving some of those benefits, but a dual eligible person through their Medicaid might not as well. And it actually gets truly really complicated for dual eligible people and for states, because it's like, are you getting personal care services through Medicaid or not? Well, sometimes we don't know. Sometimes you are. Does Medicare come first? Does Medicaid come first? I think in terms of like using supplemental benefits for caregiver supports and meeting KPIs, like in terms of meeting KPIs, like my reaction is if you want to do something really meaningful, you use that clinical model that's behind the scenes to provide these really robust, whether it's caregiver supports or some other sort of non-medical, really targeted benefit for the person. But we've got like 30 seconds left, and you are the nation's caregiving expert and a supplemental benefit expert. So what do you want to add to this?
Just that it's just never been a better time to think really creatively about how to use the Supplemental Benefit Authority and Medicare Advantage generally, not just to support Medicare beneficiaries, but also to support their family caregivers. And I think it can be an incredible membership. And I mean, CMS gets mad when you're like, supplemental benefits are for marketing. Yes, they are. That is, as far as I'm concerned, if that motivates a plan to offer a family caregiving supplemental benefit, then I'm all for it. And we're now seeing CMS offering, models in value-based care through CMMI that are actually directing Medicare dollars to family caregivers for the first time. So it's just the beginning of, I think, a very major trend towards recognizing that, Diane.
We are about at the end. I want to be respectful of folks that are remaining on the phone. Carlene, I do want to give you a chance to do 30-second wrap up. Your key thoughts folks should be aware of before we jump off the phone here.
My thoughts are: know your population, know who you want to serve, know what you're capable of providing, and how to wrap that person and that group around to keep them at home as long as you possibly can, and provide those services in the home to decrease total cost of care. I think if we wrap that population properly, we can keep that elderly person alive longer and with more quality of life than in moving them to a nursing home and leaving there because we have not managed them in the right way.
Thank you, Carlene. Thank you, Allison and Ann. Really, I'm so pleased and appreciative to be able to work with ATI today and with our team, Cope Health Solutions. So thank you all for coming. We want to be respectful of your time. This will be sent to you as we talked about, but I hope you all have a wonderful day and a happy Thanksgiving.
Thank
you.